it's an honor and a pleasure to be back in Glasgow, in Bearsden, next to David Soutar House. We are going to interview him, who is one of the pioneers who contributed to the knowledge of actual microvascular surgery. Padova University, thanks to the collaboration with Martin Webster, started the first free flaps in 1993, and I was lucky to be here as a junior plastic surgeon in 1992 to be trained in this place that is the cradle of actual microsurgery and free flap reconstruction. Together with me, there's João Anacleto from Lisbon, who had the same history.
Yes, I was lucky enough to have to share the same history as Cristina, and we're not here not only to interview David Soutar, but also to celebrate life, friendship and camaraderie as it was in Kennisburn. It has always been, it always will be.
We are in Bearsden, next to Glasgow, next to David Soutar House. We are going to knock at his door and ask him to give us an interview about his contribution to microvascular surgery.
I trained in general surgery for many years, and then I decided I wanted to do plastic surgery. And everybody wanted to go to Kennisburn because Kennisburn had been built as a purpose-built hospital to do nothing else other than plastic and maxillofacial surgery. So it was a specialist-built hospital, and it opened in 1968. I arrived in Kennisburn in 1978 as a young registrar. The chief was a man called Tom Gibson, who'd been the editor of the British Journal of Plastic Surgery for 11 years by that time. And the importance of this was that he knew what was going on throughout the whole world, because he had papers submitted from China, Japan, America, Canada, all over the world. And he knew the way plastic surgery was going. And it was he who had a great vision for the development of microvascular surgery and microsurgery. Years before, he had met Harry Bunke. And Harry Bunke, who was a pioneer, as you know, of microvascular surgery, always paid tribute to Tom Gibson for directing him along a path that was not the traditional plastic surgery path. In 1978, when I went to Kennisburn, Tom Gibson was the chief. Ian McGregor was a doyen of head and neck cancer surgery. Bill Reid was the burns and trauma specialist. Ian Jackson was there as the live wire and the innovator, and the youngest consultant was Martin Webster. And the only one who did microvascular surgery at that time was Martin. And Martin had inherited a laboratory in Kennisburn within the hospital. It was really basically a room that had 2 microscopes in it, tables where you could actually practice microvascular surgery. At that time, in the late 70s, there were very few tissues available for free tissue transfer. We had the groin flap, we had the latissimus dorsi flap, we had free jejunal transfer, but apart from that, we had very few tissues that we were able to move around and anastomose small vessels with. So I arrived not knowing anything about microvascular surgery. I never heard of microvascular surgery. And Martin insisted that I went into this little room, this laboratory, and started to practice microvascular surgery, which I did. And Tom Gibson then said what I needed to do was go abroad and really learn the clinical applications of this. So I went to Munich and studied with Edgar Beamer for 3 months. And they had a wonderful laboratory set up within the hospital where you could go any day of the week. They would just prepare things for you and you could practice and practice. And they had a huge clinical practice because they were a major trauma center. So they had become a major replantation center for Germany. They were doing emergency latissimus dorsi on legs and things like that, and groin flaps. So it was a real center for clinical microvascular surgery. And I came back in 1980 and became a consultant in 1981. So I joined Martin as the second, if you like, person who was trained in microvascular surgery. And then as things developed, we got more flaps became available. For me, it was the radial forearm flap, which the first one I did in 1982. And from there, we developed more and more flaps. Martin ran courses with Ethicon Foundation in Edinburgh. He ran 3 courses a year, lasting a whole week at a time, training other people in microvascular surgery. And Canasburn became a sort of, well, mini centre for microvascular surgery. We still had our own laboratory in the hospital where all our trainees could go and practice, and we could hone our skills if we needed to. We had great links with the anatomy department where we could go and study and develop further techniques in microvascular surgery. I think Martin and I together sort of pushed the reconstructive aspects, I suppose, of microvascular surgery. And I suppose visitors kept on coming. They kept coming to our courses, whether they were microvascular courses or flap courses or any other course that we ran. We had lots of visitors, lots of people coming for long lengths of stay, 6 months, a year, longer sometimes, to see what we were up to. And it was a time of great development. You know, virtually every week in the 80s, someone described a new flap, whether it was the fibula flap, the scapular flap, whatever. You know, every journal that you opened had another flap. And of course, this time in the 80s was long before mobile phones or internet. So the only way you could learn was either to go and visit somewhere, like Canasburn, or go to meetings, go to conferences. That's the only way you learnt about new techniques. They weren't out in the ether in the internet where you could plug yourself in and see, oh, this is how you do a perforator flap or whatever, which you can do now. So these facilities weren't available. And Martin and I wrote a little book, a little red book in the mid-80s, I think it came out, 86. And we continued to develop and pioneer and stimulate people in developing a microvascular surgery. And I think following that, I think virtually every consultant who was appointed to Canasburn after that period was a trained microvascular surgeon, because that's the way reconstructive surgery was going, whether it was in limb surgery, breast surgery, head and neck surgery, whatever. It was developing along the lines of microvascular surgery. And looking back on it, I think it was Tom Gibson, because he'd seen all these papers coming from all over the world, seeing the way plastic surgery was developing in the 70s, realizing the importance, I think, of microvascular surgery. He provided the initial stimulus, I think, for us all to go on and develop and try and get better at what we were doing. Well, I think Bob Ackland was the first person to isolate a little room in Canasburn with his microscope so that he could practice. And he was also interested in developing instruments. Remember, at that time, you know, in the late 60s, there were no instruments really for microvascular surgery. The little forceps we used, the special needle holders, we didn't really have needles that were small enough to do microvascular surgery. So if you look at Bob Ackland's development, a lot of it was laboratory based, and with a company in Switzerland called Springler and Tritt, and he developed his own instruments, he developed needles. He used the little room in Canasburn to develop all these things in the 1960s. And so when Martin became a consultant in the 70s, he inherited, if you like, this laboratory and all this previous work that had been done in Canasburn. I mean, the first paper I ever wrote was with Ian Jackson. That doesn't come as a great surprise, because when you work with Ian Jackson, it was 20 hours out of 24 hours a day. That's what you had to work, and he always insisted that you wrote a paper. So my first paper I ever wrote was with Ian Jackson. The first free flap, radial forearm flap we did was in April 1982. And at that time, there were 2 senior registrars, Brent Tanner and Louis Schecker. And the 3 of us had a month previously been at a Canasburn international course. That was when it was held. It was in March. And a man called Professor Edgar Beamer from Munich came over, and in one of his presentations, he showed us the radial forearm flap used for reconstructing hands. So when we had this case in April, the 3 of us decided really what we needed to do was the radial forearm flap. The unfortunate thing was that none of us could actually remember precisely how to do this flap. We had no photographs. We only had our memories of a short presentation. And each of us had different memories of how to do this flap. And so we raised it on the vena comitatus without the cephalic vein. And it went well, and I was very proud. So I phoned Edgar Beamer that night and told him that I had done this flap with Lewis and Brent, and we'd raised it, and we had used the vena comitatus. And Edgar said, "No, you need the cephalic vein." And I said, no, you don't need the cephalic vein. We used the cephalic vein to reconstruct the defect in the radial artery. That's what we did. And there was this silence at the other end of the phone, and I thought, oh dear, we have got this wrong. But in fact, the flap worked. So in fact, we didn't do it the way he had told everybody it was the way to use it, which was the radial artery was your arterial input and the cephalic vein was your venous drainage. We just used the vena comitatus and, as I say, used the cephalic vein to reconstruct the radial artery because we were very conscious of the fact that the criticism of this flap could be that you were taking a major artery away from the hand. Yes, I think that's right, and I think it's because she was an anatomical artist. She was used to drawing from cadavers and, real specimens, if you like. That was her profession. That was her professional job. And I think she knew, without even thinking about it, where these vessels were going. And I think you're right. If you look at some of her drawings, you think, well, look at that. There's a little branch there. Already. But we didn't know that, of course. We hadn't thought in these terms. We weren't thinking in terms of perforator flaps. We were after flaps that had big vessels that were safe and reliable. And we always did more than one vena comitatus. For that very reason, we always thought, these are really pretty small vessels and very fragile, and we're putting them onto big veins in the neck. Some of these are quite big, so. Towards the end of my time as a senior registrar, I found Ian McGregor was just so far advanced in his techniques in head and neck surgery in general, his excision techniques and the way he did a neck dissection, and he was very limited in what he could do in reconstruction. But if you think the pectoralis major flap only came in 1978, it's quite late. So before that, it was all forehead flaps and staged procedures and things. McGregor was very good at that, but his real skill was just how good he was with his hands. And he could do a neck dissection, and hardly lose any blood. And he used a knife all the time. He never used scissors. He was just so precise. And I thought, this man is just amazing. And so he really, I think, took me under his wing and was keen for me to go into head and neck, which is really what it is. So as a senior registrar, I really just immersed myself in head and neck. I didn't do a lot of hand surgery. I didn't do cleft lip and palate at all. There were some things I just decided that's not for me. I think that's true. Head and neck in the early 80s was quite a strange specialty. There were many people did it. Plastic surgeons did it. In America, general surgeons did head and neck. They had a huge society of head and neck that was general surgical based. Some maxillofacial surgeons did it. Microvascular surgery had got a bad name in head and neck surgery because the only flap they tried using was the groin flap. And as you know, the groin flap at that time was quite unpredictable. It was a difficult flap, small vessels. The survival rate was poor. It was only about 70% successful in head and neck reconstruction. And some surgeons just refused to even consider microvascular surgery. And I think if there was one contribution the radial forearm flap made was, here is a flap that is so safe, so reliable. You don't have to take it on the vena comitatus, take it on the cephalic if you want, so you've got big vessels to anastomose. This will be reliable. And of course, when we did the first reported cases, we were up in the 90-odd% success rate for the radial forearm flap, even in our first publication. So that transformed people's thinking. because the other flap people did for head and neck was free jejunal transfer, and that was also a very, very difficult transfer. The vessels were small, the mesenteric vessels were very fragile, you had a time limit of how ischemic the bowel could be, and if you didn't do the anastomosis on time or in that time frame, the thing did not survive. So I think the contribution of radial flap was, yes, it was a very useful and good flap, but I think it transformed people's ideas. Here was a flap that was reliable. The fibula flap came in about 1980. It became a very popular flap for, as you know, mandible reconstruction, particularly symphyseal reconstruction. It was a very long bone. You could reconstruct big, big defects of the mandible. I remember Peter Cordero and I appearing on the same program. He was promoting the fibula flap, and therefore I had to promote the DCIA. And of course they have different uses. Undoubtedly the best vascularized bone is the hip. It's the deep circumflex iliac. It is the best vascularized bone that we have, and you can also shape it to do half a mandible. For longer defects in symphysis, the fibula is good. But having been in head and neck surgery for years and years and years, if you look 20 years later and you x-ray your jaw reconstruction, the fibula looks like fibula and has never changed. The DCIA looks like mandible. And it's because it's a softer bone, it's a cancellous bone. It conforms to the pull and the muscle pull, so it actually reshapes itself. And when I look at some of my old cases and look at the reconstruction, it's sometimes difficult to determine which is the reconstructed side from the other side, whereas in fibula, you can always tell. Fibula never changes its spots. And I suppose that's like most free flaps. You know, if you put a groin flap into the cheek, it's groin fat that's in the cheek. And if the patient puts on weight, Martin Webster had a case like this where if the patient puts on weight, the groin flap puts on weight because the tummy is putting on weight. It's quite fascinating. I think we were doing more and more major cases. We were tackling much more difficult cases, particularly in head and neck. Age was no longer a factor. We would do major surgery, 7-8 hour operations on 70-year-old patients, if that was the best thing for the patient. But then we needed intensive care. We needed scanning. We needed access to all the other things that a big hospital has. We were doing a lot of breast surgery, again, long operations. And although we had a high dependency unit in Canisburn, we had no intensive care unit. So we needed to move somewhere that had intensive care, that had all the radiology that we would need, that had things like cardiology and cardiac units nearby. And we wanted to combine our trauma services because we were doing more and more complex primary reconstruction in trauma. Instead of staged, as we had done in the past, we were now doing primary repair, primary reconstruction, and we had to build ourselves a new trauma unit, a new emergency department. So we moved Canisburn into the Royal Infirmary into a new build that was above the accident and emergency department. So anything coming into A&E, accident emergency, any trauma, we were just upstairs. They have a lot now, yes, you're right. When Canisburn opened, it opened with 5 consultants and 2 senior registrars. When I became a consultant in 1981, it was 5 consultants. And then when you came in the 90s, it was 6 consultants. That's all we had increased in that length of time. And I think now they have 18, it's 18 consultants now, I think. 18 full-time consultants. Okay. There you go. Well, I think initially the real drive was reconstruction. We did not have techniques of reconstruction. We were still doing tube pedicle staged procedures, and we needed one-stage procedures And it was reconstruction, reconstruction, reconstruction. And then as the years went by and we got more flaps becoming available, it became reconstruction versus donor defect. We'd never thought about the donor defect or the additional scarring or the additional problems that where you're taking the tissue from. We never thought of that. It was all reconstruction, reconstruction, reconstruction. But as we began to solve the problems of reconstruction, then we had to think of, well, what is the donor defect like? And the drive to perforator flaps was really driven by a desire to limit the damage of your donor area. So the radial forearm flap became not so unacceptable, but it was quite a major thing to take a whole radial artery from a hand when you could perhaps take a perforator idea. And that's why the anterior lateral thigh flap became such a valuable tool, because here was another donor defect in the upper thigh that provided skin not dissimilar to forearm and so on. And of course in the DEP flaps, it became more perforator based, preserve the muscle, don't do so much damage to the abdomen as you did in the previous days. And we got more and more towards these little perforator flaps where what are you actually taking? Well, you're just taking a small vessel. You're not damaging the major vessels to limbs or to other parts of the body. And of course, because with that came improvements in identifying perforators. You know, either radiologically, radiology improved so much that you could actually look at not just the major vessels, you could begin looking at these tiny little vessels to see where they were. And you could think in terms of free flaps that had no name. You know, you just took a bit of skin on a perforator from somewhere. I think that's right. I think in the early days, the onus was on the technique of microvascular surgery. That's why places like Cannesburn had its own laboratory, where all the trainees could go and spend an hour or 2 hours just training and training and training. And it was all to do with that side of the reconstructive ladder. Learn microsurgery, learn to be successful, learn to put vessels together. But the whole technical side has so dramatically improved. That is not the actual most important aspect. The most important aspect now is flap design and elevation. So you need flap courses because you've got to teach the trainees how do you find the perforator, what's a safe way of doing it, what's a fast bit of a dissection for this flap, what's a slow bit for this, where are you going to run into trouble? Because failure now is very rarely technical, i.e. it's very rarely the microsurgery aspect that fails. Failure is in the elevation of the flap. You kill the flap before you've actually transferred it. So we have to, if you like, the training has dramatically changed from guys who spent hours and hours in a laboratory learning the technical skills of microvascular surgery to what they really should be doing is going back to anatomy and spending hours and hours and hours learning the anatomy of the area they're trying to raise the perforator, and how can they do it safely. I think you're right. I think atmosphere is very important. You've got to have a sort of nurturing atmosphere, i.e. you've got to welcome visitors, and the person who taught me that most, I think, was Ian Jackson. Ian Jackson was a great welcomer of visitors, and he liked visiting places himself. And so he was a great person for just sharing information, bringing people together. And I think unwinding after a long day, just where you have a wine and cheese party or something like that, and you just unwind, you chitter-chatter amongst yourselves, was a very important part of Cannesburn. Cannesburn was like a family, and it just ran like that. And I think, looking back on it, I'd be very surprised if we had mental health issues in Cannesburn when it ran like this family and everybody supported each other and everybody shared things, and then you had these unwinding things, and we had social parties as well as every week having a get-together. And I think that was very important to keeping a unit healthy in mind, body and spirit. And I think now in the health service, I think throughout the world, people are so focused on doing work and doing this. We've lost this camaraderie, and we're beginning to see The price for that is anxiety, depression, mental health issues, which I think were protected in the past by this family that just brought everybody together and said, look, don't worry about it, don't worry, you know. And particularly when you have failures, remember, when you lose a free flap, this is a major, major disappointment, not just for the surgeon, but for the whole team. Here's a team that spent 8 or 9 hours on someone, and this flap is failing. And you know what it's like, this is a terrible feeling, and you do need people to come round about and say, look, don't worry, this has happened to us all, this will happen again, you know, just figure out how you're going to solve this. What are you going to do now for the patient? How are you going to get them out of this? And I think that's really what you need to keep. And you may remember that in Canisburn we always had a meeting from 8 till 9, you know, in the lecture theatre every day. And that was an important meeting because people did have problems. Sometimes there was a pathological problem that was discussed, and everybody discussed that. All the consultants discussed that. It was very open. You know, if you had an incompletely excised tumour and that was presented, then the team would just come round and say, right, well, have you thought about doing this? Have you thought about doing that? And I think you're right. You had to have this way of encouraging people to share their things. And I remember when, as a youngster, when you were going to present a paper, you had to present it at one of these morning sessions, and it was severely criticised by all the people who were there, who would say, do not put that slide in there, it's not good enough, or it doesn't show the thing you're trying to show. And so that when you came to give your presentation at a conference, you were really pretty confident that this was a good presentation, because you'd been through it before. And it wasn't done in an unkind way, it was done in a very kind way. People suggested, recommended, helped. We didn't call it multidisciplinary, we just thought this was the right way to do it, and it saved time. You didn't have patients moving about from department to department to department, you just did it all. That was it. Yeah. One of my other phrases I used to tell people about free tissue transfer was that a flap that is half dead is a flap that's half alive.